very fortunate right now because we're in an era where in at least the lymphoid malignancies, I wouldn't say hematologic malignancies in general, but in lymphoid malignancies we have an abundance of active agents, many of them built on a therapeutic model of molecular-based therapy, others on a monoclonal antibody or immunoconjugate-based therapy. And if we can induce responses, of course, that's the first step in terms of inducing long-term survival. So we're very lucky, and this is a very exciting meeting. Before we conclude, I'd like to thank each of you, and I would also like to ask you if you have any final thoughts, pearls of wisdom for our colleagues and listeners in the treatment of the lymphoid malignancies that we discussed today. And I think we'll start with Dr. Hunger, who we've kept in the dark for a while we were talking about diseases of aging. Go back to the diseases of the young.
Well, I think the one thing we didn't talk about in acute lymphoblastic leukemia is some of the newly defined genetic subsets that have very clear, rational, FDA-approved therapies available. And there's a subset that our Children's Oncology Group and others identified a few years ago that has been called Philadelphia chromosome-like ALL. And it's called that because the gene expression profile looks very reminiscent of what you see in Philadelphia chromosome positive ALL, and you see a pattern of what is essentially activated kinase signaling. But the patients don't have BCR-ABL fusion. However, detailed genomic studies by our group and others have shown that they have a number of fusion genes that are affecting tyrosine kinase genes. So we'll see at this meeting several reports that there are at least half a dozen variant ABL1 translocations. There's variant translocations involving ABL2. There's at least 10 different JAK2 translocations, translocations involving the CSF1 receptor and the platelet-derived growth factor receptor. And a number of these in vitro behave exactly like BCR-ABL does in response to imatinib and related TKIs. And there's very encouraging anecdotal reports of dramatic patient responses. And I think this will again start to contribute to our understanding of why young adults with ALL fare poorly, because what we're seeing is that these, just like Philadelphia chromosome positive ALL, the incident increases between mid-teenage and young adult years. So I think what we're going to start to see is more genomic profiling of patients with ALL and identification of patient subsets that will also benefit from tyrosine kinase inhibitors. And I think that will start to change how we look at ALL and other diseases. And I think we're all saying the same thing, is these diseases that used to be thought of as a homogeneous entity are really multiple molecularly derived subsets of diseases that are going to respond differently to different therapies, and the big challenge is figuring out how to get the right drug to the right patient at the right time.
Good point. Dr. Lill.
Two slightly different concepts on it. One is that I think that what we're seeing with many of these drugs is the payoff of all of the basic science work into an understanding of the molecular pathways and signal transduction pathways, then applying that with the applied science of the various small molecule inhibitors. So I think the thing that's most revolutionizing our area is finally all of that basic biology is paying off now. We're stopping these pathways. The bit that I actually find more fun is the immunologically based cures. They're just kind of more, and part of this is because I'm a transplant doctor.
Yeah, that's spoken with your transplant.
But the bit that I think is going to make the most difference to people going forward are the various small molecule inhibitors.
Okay, Dr. Dewar.
In ALL or in other lymphoid malignancies, I agree with Steve, is the heterogeneity of the disease. We will be treating patients, all type of patients, with chemotherapy. In adult ALL, we are clearly establishing a better standard of care in young adults with pediatric approaches. But there will be other patients that we will know the mechanisms of leukemogenesis, define subtypes that are more homogeneous, We already know that for Philadelphia. There will be others, and that will be a different group of patients that will, with or without better chemotherapy, we will be adding targeted treatments. Now, the third thing is the new therapies do not necessarily have to apply to a homogeneous group of patients. For example, blinatumomab, the CAR, it doesn't matter what causes the disease. It's basically like a transplant and applies to all. So these are different models of treatments which all of them will apply and overall will improve the outcome.
All right, well, for you three gentlemen, I just warn you, however, that if you slice the pie thinner and thinner and thinner, it becomes more difficult from a regulatory point of view to get drug approval. So although I'm with you on the biological definitions of oncologic processes, we'll need a very different regulatory approval pathway because we won't be able to do randomized clinical trials. Already there are 6,000 adults with ALL diagnosed every year, and if you start slicing that down, it'll be very hard for us to complete a trial.
6,000 ALL in general.
In general.
Only half are adults.
Okay. Dr. Call.
Well, I'm most excited about, obviously, these targeted agents in B-cell malignancies, and one of the things that's been weighing on my mind, take the ibrutinib example in mantle cell lymphoma, response rate of about 65% and response durations of 12 to 18 months, but that means after 1 to 1.5 years, half the patients have broken through the treatment. And so the development of resistance is a major problem for all of these targeted agents. And so what I view as the next frontier is the development of rational combinations of targeted agents that can hopefully delay or maybe even prevent this inevitable emergence of resistance that happens to our patients when taking these therapies.
And Dr. Bird.
Yeah, to build upon Dr. Call's comment, I would agree, that the kinase inhibitors are an exciting avenue that we have coming forward. But something we haven't talked tonight about is their immunologic effects, and I think both the P110 delta inhibitors and ibrutinib, which also inhibits ITK, which is a kinase that's involved in immune suppression of cancer, have potential to expand outside of blood cancers to other diseases for immunologic application, and to be combined with other immunologic agents. And I think that's going to really be very exciting as we move forward.
Well, thank you, doctors, for participating and for your wise comments. And I appreciate the opportunity, as I think we all do, to participate in this conference.